Jennifer Gerard is a physician in the Hematology and Oncology unit of the Michigan Medicine. She's planning to specialize in hematologic malignancies, specifically Hodgkin's, B-cell and T-cell lymphomas. Dr. Gerard will now share information about colorectal and lung cancers. Welcome, Dr. Gerard.
Thank you, and thanks for the opportunity to share some information about cancer with the community today. I'm just going to give a little bit of background on what cancer is and specifically what we mean by a lung and colorectal cancer, and talk a little bit about why we screen for these cancers. And then if a cancer is detected on a screening test, what do we do next? And then talk a little bit about the staging and treatment for lung and colorectal cancer. And then talk a little bit about prevention, and then also how to prepare for doctor's visits to share enough information about your family's health history and your health history to provide the right level of screening and detection for these cancers. So what is cancer? Cancer is unregulated cell division within abnormal cells within an organ in the body. And this really can occur in all organs in the body, from the brain to the lungs, to the liver, to the GI tract, to the bone and blood. And cancers begin when there are a number of genetic mutations and changes within inside that cell that interferes with how they divide. And these abnormal cells go on to form a mass, and that mass starts to interfere with the normal functioning of the organ within the mass. And so we name cancers for where that abnormal cell growth starts and where that mass forms. So if that mass forms in the cells within the lung, then we call it a lung cancer. If it forms within the cells within the liver, we call it a liver cancer. If it forms within the cells within the colon, we call it a colon cancer. And a lot of these mutations can occur and accumulate over your lifetime, but there are a number of cancers that you can inherit certain mutations that put you at a higher risk for cancer. And I just listed a few here. One of them being the BRCA mutations. You've probably heard about this related to breast cancer. There's a syndrome called Lynch syndrome, where there's changes in the stability within a gene that puts you at risk for colon cancer. And there's what we call the familial cancer syndrome, or Lee-Ferrigny, which is a mutation in a gene that regulates how cells divide. And this is notable in families with multiple types of cancers. And just because you have these mutations or changes, it's not 100% guaranteed that you'll get cancer. It just puts you at an increased risk of getting cancer in the future. So you may have to undergo different screening protocols. And so a lot of times we talk about metastatic cancer. So what is metastatic cancer? Metastatic cancer is when those cells break away from the organ in which they started and move around the body. And this can occur through a system called the lymph system that is connected to our lymph nodes and is part of the immune system, or it can spread through the blood. So cancer cells can break away, move through the lymph system and deposit in lymph nodes that are head to toe in our body, or can break away and spread through the blood and form masses in other organs. When these cells break away and deposit, they are still called the cancer in the organ that they started. So if a cancerous lung cell spreads to bone, we still call it a lung cancer in the bone. We don't call it a bone cancer. And so a little bit more about lung cancer. Here's an example just of an abnormal mass in the lung. And there's two main types of lung cancer, one called non-small cell and one called small cell. In the non-small cell, there's a number of mutations that can occur within small cell that we can actually use targeted therapies. And one of these is called EGFR, another ALK, ROS, and there's some others. And how we detect a cancer and identify a cancer, if you can see on the bottom, there's cells here, and let me see if I can get a pointer up. On the left, there's a collection of cells that show normal lung cells. They're well organized with small purple nuclei and some staining. And on the right bottom, under the lung cancer picture, you can see disorganization of these cells. And this is what a cancer looks like under the microscope. And so what is a colorectal cancer? So colorectal cancer forms in the colon, which is the last part of the GI tract. It's attached to the small intestine. and goes from the cecum, which is attached to the small intestine, all the way through the rectum. And a colon cancer forms in the cells, mainly in the lining of the colon. And there can be an inherited type of colon cancer called Lynch syndrome. And in the picture, you can see, this is a picture from a colonoscopy, which we'll talk a little bit about. And you can actually see a polyp there and some abnormal appearance to that polyp that tells us that this is likely a cancer. And so, you know, the goal is to catch cancers early so we can treat them and cure them. And so the United States has set up screening protocols, cancer screening. And the goal of screening is really to screen for cancers that we can catch early by simple, non-invasive methods. And when we catch that cancer, we can treat and cure it. And we can catch it before symptoms start, before it becomes an advanced stage cancer, and allow patients to experience cure and save lives. So we only screen for certain types of cancer because all types of cancer we can't reliably identify, and all types of cancer we can't treat and cure. So the types of cancer we tend to screen for are prostate, breast, lung, colon, cervical cancer. But we don't tend to screen for cancers like ovarian, pancreas, stomach cancers because we don't have a reliable way of detecting them, and we don't have a reliable way to treat and cure them. And so how do we screen for colorectal cancer? So we recommend screening colorectal cancer for the general US population. And typically the screening starts at between age 45 and 50. There are a number of guiding bodies that tell us which age to start screening. So that's why there's a range from 45 to 50. And you might see in the next few years that might be getting even younger, because we know that there's starting to be a population of young patients who develop colorectal cancer before the age of 40. And we usually stop screening around 75 because we know that even if we detect a cancer in an older population, we may not be able to treat and cure it in the way that we would want if we were to detect a cancer. And so we tend to screen certain populations earlier based on risk factors. And the risk factors, the number one risk factor is if you have relatives with colon cancer, you'll start screening before the age of 40. Other diseases that put your colon at risk for cancer, like inflammatory bowel disease or rare conditions called sclerosing cholangitis. And kind of the gold standard for colorectal screening has been the colonoscopy. And a colonoscopy is a camera that searches the colon to see if there's any abnormal areas within that surface of the colon, or if there's any polyps, which is a small area, small mass of rapidly dividing cells. Now, the colonoscopy requires fasting, meaning you can't eat before the procedure. It requires a prep, meaning that they give you some medicines to help clean out your bowels. And it usually requires a day off work and some sedation. So it does take some planning and some time off work to complete this screening. However, the advantage is that you can actually treat and remove polyps with this screening procedure. And if there is a cancer found, you can take a sample of it right there and have a diagnosis of the cancer, and you don't need to go under an additional test to get a biopsy. The other advantage to a colonoscopy is that if the colonoscopy is normal, you don't need to be screened again for another 10 years because colon cancer progresses in a very predictable fashion. So if your colonoscopy is normal, we know that your chances of getting cancer within 10 years are low. And it's most reliable test for detecting a cancer. It detects 95% of cancers within the colon that are there. The other tests, the advantage to the high sensitivity guaiac, the FIT test, and the stool DNA test is that you can actually do these at home. So it requires a small stool sample that you do in the privacy of your own home and either bring back to your primary care doctor or you send in to a company that will run the test for you. And what this is actually looking at, this guaiac is looking at a small amount of blood in the stool. The FIT testing is looking for certain proteins that tell us a cancer might be there. And the stool DNA is looking for bits of DNA that tell us the cancer might be there. These tests are usually done yearly. The stool DNA is done every 3 years. They are worse at detecting cancer. So even if your test is normal, there still is a small chance that you might have a colon cancer that we did not check. The other thing with these stool tests is that if they are positive, you will likely have to undergo a colonoscopy to see if there are polyps there or to see if the cancer is there to undergo that biopsy. And so why would we want to do these screening tests? So deaths from colon cancer have decreased by 50% from 1990 to 2017. So the screening process, in addition to improvements in treatment, have really decreased the deaths from colorectal cancer significantly. And here's just a picture of what a colonoscopy procedure can look like. And here's an example of this stool sample test kit. And so how do we screen for lung cancer? So lung cancer is a little bit different than colon cancer. In lung cancer, we know the advantage for screening is only in a high-risk population. So we don't screen everyone for lung cancer. We only screen people who are at high risk. And these include people over the age of 50 who have smoked for at least 20 years and stops at the age of 80. And the test for lung cancer screening is called a CT scan. And the picture here kind of denotes what the CT scan looks like. You lie on a flat bed, you undergo a scanner, and it produces pictures of the lung that can identify a lung mass or a lung nodule that can look like a cancer, okay? Now, the thing with lung cancer screening is there is a good chance that it's going to detect a nodule. Meaning they detect nodules in 40% of the tests that they do. And so these nodules can look on the CT scan like just a small change. It can look suspicious for cancer, or it can look very suspicious for cancer. So oftentimes with lung cancer screening, you will likely undergo further tests, and that could just be simply another repeat CT scan in a number of months, or you may actually have to undergo a biopsy, which is a procedure to take a small piece of that abnormal tissue to look at under the microscope to see if it's cancerous. And why would we want to do cancer screening? So if we catch a lung cancer early and through the clinical trials that have been performed for lung cancer screening, it decreases your chance of dying from lung cancer by 20%. And so what happens if we detect a cancer with these screening protocols? So the standard diagnostic procedure that we need to diagnose a cancer is called a biopsy. We take a small piece of the abnormal tissue and look at it under the microscope. If you got a colonoscopy and it identified a cancer, that would serve as the biopsy for the diagnosis. If you got a lung cancer scan, a CT scan, you would likely need to undergo a procedure called a bronchoscopy, where they look down into the breathing tubes, into the lung, and take a small piece of tissue, or sometimes they can go through the skin into the lung to get a small piece of tissue. And what they do is look at under the microscope to look for cancer cells, and then do special staining to identify the genetics and the markers within that type of cancer to give a final diagnosis. And then also, once they detect a cancer, we need to look for it other places. So you'll likely need to undergo other scans, like CT scans, sometimes MRIs, and sometimes a specialized scan called a PET scan to tell us where the cancer is in the body, if it's just in the organ within where it started, or if it's spread to other lymph nodes or other organs in the body. And the other thing that I want to note here is that from detection to treatment, this can take about a month. And I want to say that because this is usually a pretty unsettling time for patients as they're awaiting this final diagnosis and treatment plan for their cancer. But the reason why it can take this long is because we need to do all those specialized staining and those specialized scans. So we make sure that we come up with a treatment plan that provides the highest rate of cure in the safest manner. And so once we've detected this cancer, how do we stage it and how do we treat? So when we talk about cancer staging, we're really talking about gauging the extent of the cancer. So when we're talking about a stage 1 or 2 cancer, we're talking about it being localized to the organ where it started. So if it's a colorectal cancer, it means the tumor is within the colon or just invading through the colon wall. If it's a lung cancer, usually the tumor is within the lung, or the tumor is within the lung and involving just the small number of lymph nodes around that lung tumor. When we talk about a stage 3 cancer, that means it's still localized, meaning in the area where it started, but has spread a little bit to the lymph nodes around that area. And when we talk about a stage 4 cancer, that's when it's spread to other organs in the body. For colorectal cancer, it usually tends to spread to the liver and the lung. And for lung cancer, it typically tends to spread to the space around the lung and to liver, bone, and brain. Okay. For stage 1 and 2 cancers, we typically treat with surgery to remove the cancer. For colon cancer, this means a colectomy, which means taking out part or all of the colon and taking some of the lymph nodes around the colon. And this provides about a 90% cure rate, meaning that 90% of people will be alive in 5 years. So you can really see the advantage of catching a colon cancer early because your chance of cure is quite high. And with lung cancer, as you probably noticed, we screen a lot more frequently. It's in general a more aggressive cancer. So when we catch it at an early stage, we can still cure it in about 60% of people, but in about 40% of people, the cancer will keep growing despite our best efforts with surgery. When the cancer has spread to the lymph nodes, we usually need to do a little bit more than just surgery. So when it spreads to the lymph nodes for colorectal cancer, it's usually paired with chemotherapy. When a lung cancer has spread to lymph nodes around the lung, we usually treat with chemotherapy and radiation therapy, and we do not do surgery. And even in a stage 3 colon cancer, the chance of cure is quite high, around 70%. Once again, lung cancer is typically a more aggressive cancer. So at stage 3, the chance of cure is only about 20 to 30%. And when it's a stage 4 cancer, usually we're talking about keeping the cancer at bay for a period of time. And there's very, very few people when the cancer has spread that can make it to 5 years. Now we know that with stage 4 cancer, that certain mutations we can target with therapies. And if you have these mutations, overall, you have a better chance of survival and a better chance of living longer. So there is a chance with a stage 4 cancer that you can live past 5 years. And so it's worth talking about what if we cannot treat a cancer. So for colon and lung cancer, if we detect it on a screening test and it's early stage, there is a good chance of cure. But for people who have symptoms and present with a cancer that's a stage 4 cancer, sometimes we cannot treat it. And this could be because there's liver or kidney dysfunction, because the cancer biology just is not going to respond to treatment, or that you've tried treatment in the past and the cancer is just not responding to therapy anymore. And so then we shift the focus from cancer therapies like chemotherapy or immunotherapy to supportive services called palliative care and hospice. And I really want to highlight here that choosing palliative care and hospice is not giving up. It's just a different way of treating cancer when we cannot use the therapies that we would typically use because the cancer is not going to respond. And we know with patients with stage 4 cancer that are not responding to therapy and that have a low chance of responding to therapy, early enrollment in palliative care and hospice can actually extend life, because giving therapies that have a lot of side effects can shorten life because of infection, because of hospitalizations, because of fall and weight loss. We know that these services can actually extend life in certain circumstances. And so I just want to talk briefly about things that we can do to prevent these cancers from occurring. So the biggest thing with lung cancer is that 85% of lung cancer deaths are from smoking. So stop smoking, stop smoking, stop smoking. It's the single best thing that you can do for your health if you're a smoker. And you can actually gain years of life back. So if even in your 50s, if you've smoked, if you stop smoking in your 50s, you can add 6 years back to your life. That's pretty significant. And the other piece of advice is don't quit quitting. On average, it takes a smoker 7 attempts to quit smoking. And there's a lot of resources out there that you can access. And just because one way of quitting doesn't work, there's usually multiple ways to try to quit smoking. So I've put the quit line and the CDC website for resources for quitting smoking. And for prevention for colon cancer, the biggest thing to do is diet and exercise. And I think an advanced nurse practitioner, Cunningham, summed up recommendations for healthy living quite well. So I'll just kind of briefly state shopping the perimeter with the green leafy vegetables, fruits and vegetables, and unprocessed meats. And then taking a walk 20 minutes a day, at least 5 days a week at minimum for exercise, and then keeping a healthy BMI. And then what can you do to prepare for doctor's appointments to make sure that you're screened at the appropriate time based on the risks in your family? So collect a family history. Spend a little time talking to your family about histories of cancers, histories of blood clots, autoimmune disorders, heart disease, and diabetes. And the last thing that I really want to highlight here is, we all hope to live into our 70s and 80s, and we all hope to be healthy, but sometimes that's just not in our plan. So it is worth spending a little bit of time with your family, talking with them about your wishes if you were to get sick in terms of your treatment. And this includes identifying a decision maker if you were to get too ill to make decisions for yourself about your health, and talking with that decision maker about what you want for your care at the end of your life. And I put some resources here. The way to put this in writing legally, so it's binding when you are hospitalized or when this time does come, is a durable power of attorney. And U of M has some really good resources in putting this together, and I put them in the chat link. And then just the last piece of advice here, there's a lot of information out there on cancer. Be very mindful of where you're collecting your information. These resources are good resources that have evidence-based backing to their claims and will put you in the right direction when thinking about cancer. So cancer.net is from ASCO. The CDC has a great series on cancers, both prevention and detection. And the Mayo Clinic also has some good resources for patients as well. And thank you.